안녕하세요. Hello everyone watching this video from around the world. My name is Su-Jin Yang from Korea and I will be participating as a moderator in today's surgery. I am currently working as an assistant professor in the Advanced General Dentistry Department of Yonsei University Dental Hospital. We are now broadcasting live in Samsung Dentium Center in Seoul, and I would like to welcome you all to another live surgery brought to you by Dentium Corporation. With the COVID-19 crisis becoming a long and hard fight, there have been many challenges. Therefore, I deeply thank Dentium Corporation that has made today's seminar possible, and I believe that with today's online seminar, as well as the many webinars Dentium has yet to offer, we will be able to actively share information and experience amidst this COVID-19 crisis. Today's operator is Dr. Kang-Hee Lee, who will be showing us another case covering both the surgical and prosthetic fields of implant dentistry. I hope that today's seminar will be both intriguing and inspiring to you all, and I will try my best to convey as much information possible from the operation room. I also wish that through this seminar you will be able to have a better understanding of the Dentium implant system and GBR materials or additional tools that we will be using in today's case. We also have a comment window below the video open while running live, so please feel free to express your thoughts or questions anytime during this seminar. Please note that we will also be having a short Q&A session based on your questions at the end of today's surgery, as well as a concise briefing of today's outcomes. Okay, first I will briefly introduce today's case before we move on to the operating room. During today's case preview, Dr. Lee will be performing local anesthesia on the surgical sites and will be preparing the operation. Today's case will be covering implant surgery and immediate prosthesis using Bright implants, Dentium guide, and pre-made temporary prosthesis. And immediate loading will be performed on the posterior areas. Now, if we have enough time, we will also go over a similar case, so we will have a clear view of what today's case will be like. Today's patient is a 70-year-old male, and he came into the clinic with the chief complaint that he wanted to have teeth in the upper jaw. The patient was using an old removable partial denture on the maxilla, but recently could not use it after he had tooth number 13 extracted several months ago. The patient confirmed that he was moderately comfortable with the denture occlusion. In terms of past medical history, the patient was taking aspirin every day along with other hypertension medications. Therefore, straightforwardly, today's surgical plan is to place 6 implants in the number 17, 16, 15, 13, and number 26 and 27 areas, using Dentium Digital guide and Bright bone level implant fixtures, and to connect immediate implant prosthesis using pre-made temporary abutments and bridges. The sites of each implant area will be explained in the following slides. Now, this is the panoramic radiograph taken recently for today's surgery. The X-ray shows a dentulous ridge in the upper right and left molar areas. The upper right canine extraction site shows countable bone loss, and it seems like a challenging site for implant installation. The lower teeth show moderate alveolar bone loss, but no significant mobility was found. Tooth number 11 shows apical radiolucency, and I hope the patient receives root canal treatment on this area in the further visits. Now, these are the intraoral photos of the patient. From the frontal and lateral views, you can see that the patient has deep bite with an open bite of over 4 millimeters. Tooth number 33, 34, and 35 show moderate to severe attrition, or say even more attrition compared to the other teeth. That is probably due to the opposing porcelain crown on the upper left area. Now, from this, we can plausibly guess that the heavy occlusal forces and guidance was applied on the left canine and premolar areas, but could nonetheless withstand tooth loss. because they were splinted as a fixed bridge. However, the upper right canine, which is missing at the moment, probably developed periodontitis, which led to extraction due to the traumatic forces laid upon this tooth, which would have acted as a sole abutment tooth for the removable partial denture. Keep in mind, the upper left second premolar showed vertical bone loss in the panoramic view, which is a sign that can indicate excessive occlusal force upon this area. Now, overall, the patient shows dental signs of vertical collapse and attrition, and shows slight mandible shifting to the right side, which is also probably due to loss of posterior support, which is more prominent in the right area. Yet the patient did not present any signs of TMD or joint problems and was comfortable with the current occlusion and jaw position. So this position was used as a base reference for designing the temporary prosthesis we will be using today. The crown height space is 7 to 8 millimeters in the right side and will be a bit challenging compared to the left area. On a personal note, I believe that Dr. Lee will first keep this jaw position and see whether the patient is able to cope with the provisional implant bridges, and during temporalization, we'll make adjustments to confirm the changed jaw position and vertical height for the final implant prosthesis. Now, as you can see in these photos, the upper right canine area shows horizontal as well as vertical bone loss. So we can assume that quite an amount of GBR will be needed to be done in this area. Attrition can be seen on the lower canines and especially on the lower left premolars. As practitioners, we all know that losing mutual protection from the anterior teeth can be a devastating etiological factor. No guidance from anterior coupling always has a bad influence in worsening the posterior interference, leading to poor prognosis of the final prosthesis. This especially can be more critical in implant prosthesis because implants are, as you know, vulnerable to lateral forces. Now, even with the excelling outcomes of improved implant surfaces and fixture designs, it is still very important to have such prosthetic concepts in mind during the whole treatment procedure for more promising results. Now, we will go over each side upon the CT scan. First, tooth number 17 area shows sufficient bone width and height. Same goes for tooth number 16. Tooth number 15 area also shows no significant bone loss. However, as we mentioned before in the previous slides, tooth number 13 area shows both horizontal and vertical bone loss. Therefore, GBR will be done in this area. Tooth number 26 and 27 areas show sufficient bone width but moderate height of approximately 6 to 7 millimeters. Dr. Lee plans to do an additional bone graft in these areas using the crestal approach simultaneously with implant placement. As I mentioned before, same goes for tooth number 27. Now, the following slides represent the cross-sectional view of each implant position following the analysis of the CBCT. We will be using Bright implants from Dentium, and the size of the implant is shown on the upper right of the slide. For example, Dr. Lee plans to put an implant having 4.5 diameter with 9 millimeter length in the tooth number 17 area. For tooth number 16, we will be using the same size. 15, a 4.0 diameter implant with 11 millimeter length. I believe the trickiest part, tooth number 13, that would be, shows a rather wide bone loss. So if Dr. Lee were to place the implant in this area according to this plan, he will have no buccal bone. A notable amount of bone graft will have to be made upon the length of the buccal side of this implant for bone housing and bony thickness enhancement. An additional soft tissue grafting can also be done for better aesthetic outcomes, since this site shows deficiencies in soft tissue as well as hard tissue. We will see how Dr. Lee manages this area in the operation room. Tooth number 26 and 27 areas shows insufficient bone height. The planning shows that implants in having 7 millimeter length fit for this site, but I believe Dr. Lee plans to do an additional bone graft in these areas using the crestal approach and to place a 9 millimeter length, 4.5 diameter Bright implant. For immediate restorations, many factors must be taken into account. Before surgery, the surgeon can analyze the bone density through the CT scan, and keeping that in mind, can make adjustments in the drilling sequence to allow for sufficient initial stability during implant placement. This is especially important for cases including the anterior areas, so we can guarantee the patient's social life from the point he leaves the clinic. Suffice to say, we don't want the patient looking like they have received nothing after all the heart we had put into. Now this is the overview of the entire treatment plan. Although tooth number 13 looks like it is positioned too much to the palatal side, the coronal 1/3 will be angulated to the buccal side. So we could use as much bone possible in the apical 1/3 for implant fixation and to allow for a reasonable platform position for the canine crown restoration. The yellow crowns in this slide show the outline of the prefabricated provisionals. This is the overview of the planned STL file of the provisional crowns that will be prepared before surgery according to the implant sites. I believe tooth number 13 and 14 is made as a ponic and will not be connected to the implant fixture today of tooth number 13 area to guarantee minimal interference to bone graft healing. It looks like the provisionals show edge-to-edge relation on the right molars, but we will see if any adjustments were made or will be made when we go into the operation room. The implant positions as well as anatomic references can all be confirmed through the planning procedure. What is good about the digital guide software from Dentium is that the surgeon can easily make additional adjustments considering the crown shape, angulation, by three-dimensionally rotating the patient's scan file within the software. Also, the angulation of the fixtures and hole positions following each implant angulation can also be easily confirmed. This slide shows the overlap of the patient's cast scan file and the CBCT file, so the bone anatomy can also be confirmed in the process. On a personal note, I usually, when I treat my patients, like to check the actual tooth angulation that can be seen from the CBCT scans. Now the guide template, temporary abutments, and temporary crowns are already made through this process and delivered to each clinic before the surgery. And this is the photo of the abutments and bridges made according to 3D planning. Dr. Lee, I believe Dr. Lee seems ready, and so does the patient. As I've mentioned before, we have a comment window below the video, so please feel free to express your thoughts, questions, whatever, during this video. And we will be back with you from the operating room. Thank you very much. Okay, first, I believe Dr. Lee is fitting the surgical stent. Today we have metal sleeves within the template. And Dr. Lee is first checking the sites where he is going to make the incision lines. If you would have checked, but he made points from the palatal area rather than from the middle of the actual hole. Usually, many practitioners prefer to make incisions that are shifted 2 or 3 millimeters maximum to the palatal side when they are treating the maxilla cases, because anyone would know that the palatal side of the flap is very hard to reflect, and we want to preserve as much keratinized or attached gingiva possible. So this kind of deviated incision is a very helpful way to start any case that is dealing with implants on the maxilla area. Okay. Dr. Lee is using the mold curette to reflect the surgical site. I believe there is going to be quite amount of granulation tissue in the tooth number 13 area, so it would be very important to be careful not to tear any gingiva on the tooth number 13 site. According to your preferences or the amount of GBR that has to be done as a result, you can start reflecting the flaps with a vertical incision from the beginning, or add an incision whenever it is necessary. Okay, so that is the granulation tissue I was talking about in the case preview. Usually, the sites that have been through elongated inflammation, there are deficiencies in both soft tissue and hard tissue. So, according to the surgeon's perspective, he or she can plan to do an additional soft tissue graft as well. If Dr. Lee plans to do so, I will explain furthermore as he puts the graft materials in the implant area. Okay, so as you can see, there is horizontal and vertical bone loss in tooth number 13 area. Okay. I believe the key to any implant surgery is to have maximum visualization of your surgical site. So it is very important to clean with a clean motion, have the sites reflected, and to have bleeding control upon the area. I'm pretty sure that the patient was taking aspirin regularly before the surgery, and according to the patient's medical doctor, we can plan to discontinue these antiplatelets or anticoagulants in some cases before surgery to ensure that the patient won't have too much bleeding during the surgery. Okay, so Dr. Lee just undermined the granulation tissue from the tooth number 13 area, and he is checking whether there are any remaining soft tissue within the reflective flap. Okay, he's also making an incision on the tooth number 26, 27 area, making a crevicular incision along the tooth number 25 area, a small vertical incision on the rearmost area, So as you can see, the incision line is deviated to the palatal side. So we will have the edge of the fixture platform of the palatal side right next to the incision line. If we were to reflect the flap from the mid-crestal portion, then we would have to have more palatal side flap reflection to ensure implant placement, which would be a tedious work for the surgeon. Okay. Although tooth number 13 area had more granulation tissue than the site that we are doing right now, I believe there is a bit more bleeding in this site. This can differ from case by case, from patient to patient, so no worries needed at the moment. Okay, Dr. Lee is once again fitting the surgical stent. As you can see, there are windows. There is a window on the tooth number 22, 23 area. And since the stent is securely positioned, but has a free end on the posterior side, it is always very important to secure the stent in the correct position. So as you can see, Dr. Lee is firmly pressing onto the stent with his left hand and is performing initial drilling with his right hand. And I believe it is a diameter of 2.2 millimeters initial drilling. And we will see that in the further steps, Dr. Lee will be preparing additional bone graft in the 26-27 area. If the stent moves around, then there is actually no reason why we are doing this guided surgery at the first place, because the first reference point would be different. So the surgeon and the assistant has to always check if the template, the guide, is always firmly and stably set within the patient's mouth without any lateral or posterior movement. Okay, so he's moving on to the next drilling sequence. That is a 3.5 with a 7 millimeter. So the floor of the sinus on the 26-27 area was a 7 millimeter. So he is drilling upon that length. And I believe as he builds up, he will be performing the sinus lift from the crestal approach. Now he is moving on to a 4.0 diameter drill sequence. The implants we will be using today is a Bright implant from Dentium. And this is a taper. The shape of this implant is taper shaped. It is a bit different from the superline concept, which has a parallel portion within the mid length of the implant. So since it has a continuous taper, it is much easier and simpler to insert within the osteotomed area. Okay, he is performing the guide drill once more, and he will build up in size. The RPM Dr. Lee is using is 2,000 RPM with this can also differ from surgeon to surgeon. Okay, so if we have too much bleeding in a particular site, direct anesthesia can be done in the bone prepped areas, because we have epinephrine within the ampule that we are using for dental anesthesia. It is a very quick and efficient, straightforward way to deal with excessive bleeding in such sites. Okay, so he is continuing with the drilling sequence. Now using a 3.5 millimeter diameter drill. Moving on to the next sequence with 4.0. Okay, like I've mentioned before, the tooth number 13 area probably won't have any buccal bone housing when we are done with the drilling. So it is very important to follow the drilling sequence that is recommended from the manufacturer's plans. As we've mentioned before, the posterior implant heights or lengths will be 9 millimeters, and he is now building up the diameter sequence. Usually an up and out, as you would all know, the up and down motion is recommended to allow for copious irrigation because we don't want any overheating in the surgical sites. Without enough irrigation, the drilling sites might become too overheated and cause tissue damage or bone necrosis, or cause any other side effects that would affect the osseointegration between the patient's bone and the implant. Okay, so Dr. Lee is first placing an implant in the tooth number 16 area. We are using Bright implant that has 4.5 diameter and 9 millimeter length. And this is a bone level implant. It is always, when we are with practitioners that are not very accustomed to the implant systems or designs, it is first very important to decide whether I'm going to use the bone level implant or a tissue level implant. The indications and pros and cons is another great topic for a seminar or a lecture, and probably you would have a general good idea of what you will be using, but still it is a very important part that we should not miss when we are treating our patients. Okay, this I believe is the hand ratchet that he will be using. Okay, implant installation in tooth number 15 area with a 4.0 diameter and 11 millimeter length is being used. The insertion RPM is 30, set to 30, and Dr. Lee is using 70 newtons for his implant placements. Okay, so in places where we have bone defects, it is important to, we have a bit more granulation tissue in that area. Okay, so Dr. Lee probably would have felt that when he was drilling in this place. Okay, so that's removed. It is very important to check the prepped areas even after your final drillings, because there may be any soft tissue or granulation tissue remaining inside the prepped site or even around it. So it's always safe to double check. This is especially very important if you're planning to do an additional GBR in the surgical site. Okay. So as you can see, the position, the height of the platform of the guide is different from to position. That is because we have about a 4 to 5 millimeter offset from the platform to the from the guide platform to the actual implant platform. And the length of the implant we will be using is also different from site to site. Okay, Dr. Lee is now inserting a 4.5 millimeter diameter implant with 11 millimeter length in the tooth number 13 area. We are performing the surgery in a very safe and straightforward way using the Dentium guide, but it is if we were to make adjustments in the implant placement, because the situations can differ, because you can say that you fit the template within the patient's mouth, but you were like, I really don't like this position. I want it to be a bit more angulated to the buccal side. Then you can just take out the template and manually insert your implants. And in these processes, the remaining teeth, that is, in this case, for instance, tooth number 12, can be a very good indicator for your canine angulation. Okay, so Dr. Lee is first inserting the collagen membrane with a 10 millimeter width, 20 millimeter length size. This is a collagen membrane from Dentium. The Dentium collagen membrane, I believe, is a bit more stiff compared to other products from other manufacturers. I have many experience using this kind of this product as well. And it's very good for because it is a bit more stable compared to other products within the market. And the graft material used today is osteum 3 collagen, which is a synthetic bone embedded in collagen matrix. Because we have collagen within the graft material, it is much better to forge, that is, to build up the graft material, and it stays in one bulge. So if we were to use a particulated bone, we would have bone scattering everywhere, which we don't want. So this is a very convenient and good kind of implant. Okay, so since we don't have any buccal bone housing, the tricky part would be that the initial stability in this area is a bit more tricky, a bit more hard to achieve compared to other areas. But I believe Dr. Lee would have done a magnificent job on that topic, and he is now putting in the cover screw. Maybe the screw is a bit short, or maybe if he would use something longer. Oh, he's moving on to tooth number 26, 27. Okay, now he is getting ready to perform the sinus floor lift. That is a bone graft from the crystal approach. So I believe he is first trying to penetrate the sinus floor, lift it using the osteotome. Usually the osteotome that the surgeon picks is the same size or one size bigger than the drilled, that compared to the diameter of the drill that we used. Because if we were to use something a bit more bigger, then we can also have a side effect of compacting the bone when we are lifting up the sinus floor. So that is an additional thing that we would want, because the bone density in the upper molar areas is very low compared to other areas. So one more step for increase in initial stability is always welcome. Okay. When using the osteotome, it is very important to concentrate your sensation on the fingertips, or because when you perform the osteotome, a sudden rush into the sinus can be felt when you are performing the malleting procedure. So after you've felt it, you can either check that the membrane, whether the membrane was perforated, with the additional tools that is usually presented within the sinus floor elevation kit or crystal approach kit. We also have a crystal approach kit from Dentium, which I think is very useful, and it's very simple. So now, as I've mentioned in the patient preview presentation, Dr. Lee will be adding some bone into the elevated sinus and be compacting the bone graft material using the osteotome. The black material that was put on a cap on the osteotome is the safety stop for the osteotome. So in cases where you can't see the lines drawn on the osteotome, you can always use those kinds of safety tips so that the osteotome won't go further into the sinus than the length, than the length that you prefer to. Okay, now Dr. Lee is putting in a Bright implant with diameter. Oh, I think there is some mistake. Oh, okay. Okay, 4.5 diameter, 9 millimeter length. Bright implant in the tooth number 26 area. Since we have bone material compacted in the apical portion, and this is like a closed space, we won't have any particles falling out during the implant procedure, even if we are using irrigation like Dr. Lee is doing right now. But if you don't want that happening in any way, then you can turn off the water and slowly place your implants. Okay, in the same way, 4.5 millimeter diameter with 90 millimeter length, implants were placed in the tooth number 26, 27 area. Okay, like I've mentioned before, this is the collagen graft material that is a substitute for soft tissue. Hard tissue deficiency and soft tissue deficiencies. We want to have some augmentation on the soft tissue level as well. So an additional soft tissue graft material can be used. It looks like a sponge in a way. Okay, so I believe the tricky part will be tooth number 13. It is very hard to secure initial stability. One way to make sure you have increased initial stability is to go in deeper, or a second way is to build up the diameter. And I believe Dr. Lee is checking with the team whether we have implants in other sizes. Okay, while Dr. Lee is getting ready, one thing I've noticed about Bright implants is that the connection area of Bright implants are rigid, making them very resistant to sinking and fixture tearing. So we will have that as a pro in the further prosthetic work done after the surgery. Okay, so a 4.5 millimeter with 11 millimeter length for tooth number 13 is being reinstalled. Same way the torque was set to 70 newtons. Bleeding is always the problem in cases where we want visualization of the surgical site, but okay, now Dr. Lee is putting in the cover screw. If we, in sites where we can't have enough initial stability as we would want it to be, it is very important to carefully put in the cover screw, or else we would be having horizontal forces put onto the implant. So also keep that in mind. Okay, the soft tissue graft material is set over the collagen membrane. That would act like a double membrane technique in sorts, but with another type of membrane. Okay, additional bone graft is being done. As I've mentioned before, osteon collagen is being used. Okay, and he's now performing the sutures. Whether you want to have a reverse triangle shape cutting tip for your suture needle or a round type differs from surgeon to surgeon. I believe he is using a 4.0 Vicryl in today's case. Usually the thicker your suture material is, it is more rigid, so it is a bit more easy to manipulate or to use and to secure the flap in the right position. But in places where we are having, say, like vertical incisions, not like in this case, but with patients, say, having very thin gingiva, then if the needle or the size of the silk is too thick, then the membrane might break. We may have some flap tearing, which is another consequence we do not want. So the preference or choice of suture material is another issue. So please also keep that in mind. Since I believe there wasn't much volumetric change of the buccolingual dimension and the tooth number 13 site, so no additional, say, like releasing incisions were mandatory in that grafted area. But in cases where we were to build up more dimension in the buccolingual area, then additional vertical incisions or releasing incisions would be necessary. So when performing the bone graft, it's always important to check whether your flap will be fully covering your surgical site after graft placing or graft molding. Okay, so since tooth number 13 area is done, now I believe Dr. Lee will be moving on to placing the temporary abutments to fix in his temporary crowns. So we are starting with the upper left side, which is a bit more simple because we only have 2 teeth to make. Usually the temporary abutments are have non-hex connections. That is, since we don't know how much rotation or depth the final installed implant is going to have within the patient's mouth, it is very hard to make temporary abutments using a hex connection because we don't have any designated rotating position. So usually for these temporary cases, a non-hex abutment is used, but on the other hand, like vice versa, we don't have any reference to position our non-hex abutment. So usually a pre-made jig is needed to seat the temporary abutments first. But in this case, Dr. Lee is using a very smart and simple method of using his temporary crown as a jig. They're very straightforward. So since we have a lot of bone graft and soft tissue graft on the tooth number 13 area, we don't want the implant to be disturbed with any occlusal forces. So we will be just burying that tooth number 13 implant within the grafted bone housing and the patient's bone housing. And probably tooth number 13 and 14 crowns will be made as a ponic and be attached to the 15, 16, 17 bridges as in a free end way. Okay, so Dr. Lee is first placing his temporary abutments on the bridge. In the same way, he will probably be using his temporary bridge as a positioning jig. If there was a bit more buildup in if there was a bit more buildup in the grafted area, maybe the volume of the sutured tooth number 13 area will be too big and would hinder the seating of the ponic of the tooth number 13 area. So in such cases, the surgeon or the practitioner can reduce the internal side, that is the gum side of the tooth number 13 ponic, to allow for the setting of the temporary bridge. And we don't want the ponic to be pressing onto the grafted area, otherwise it would disturb the healing of the surgical site. So anyway, the surgeon will check twice before he sets his bridges. Usually the temporary bridge is made with an internal gap of 0.3 millimeter to 0.5 millimeter. And an additional relining is usually necessary, but since this video is running long, as it is, I believe Dr. Lee will be just checking the position of the temporary bridges and be seating, connecting the abutments to his implants. Usually the more units you have, the more parallelism you have between the crowns. So in some cases, an additional relining is not always necessary, and the temporary bridges can be set with temporary cement it all depends on the clinical situation. And as I've mentioned before, the vertical height of the upper right area, is the crown height space is a bit shallow. It's a bit small compared to the left side. So the crown heights are a bit shorter than compared to the tooth number 26, 27 areas. Okay, the temporary abutment is being secured onto the implant. Okay, so as you can see, the temporary bridges are acting as a jig. I believe the ratchet is a bit slippery. So the temporary bridge is used as a jig as well, simultaneously in these cases. So if you want to use the bridge as a jig, as you are seeing now, you want to make sure that the holes are made on the bridges before your surgery or placing the bridges. Okay, so Dr. Lee is checking the occlusion. Make sure that the bridges are stable and don't show any, well, let's say, like anterior-posterior movement. I believe the crowns are a bit loose, so maybe an additional relining would be necessary. Okay, but before that, it is more important to finish with the suturing. To ensure promising outcomes of the bone graft area, it is essential that the flap is secured under minimum tension, but the collagen membrane from Dentium is, as I've mentioned before, is a bit stiff, and is nonetheless easy to manage after it is wetted. So there is a bit of a dehiscence between the flaps in this area that you are seeing now, but because we have used collagen membrane in this area, it can act as a barrier even in some, say, like open membrane cases. Oh, that was easily managed. In cases where we have patients having some more bleeding than compared to other patients, it is always good to see that the bleeding ceases after we have secured the flaps into the right positions. So the suture is a procedure that is very generally done among all surgeons, but it is a very important step in securing the flap into its position and making sure that the healed soft tissue will stay in place and stay with the preferred, say, volume or position even after healing. Okay, so I believe Dr. Lee will be finishing his sutures, and I think we've discussed pretty much the important parts of today's surgery. So after Dr. Lee finishes his surgery, he will be taking some x-rays and a CBCT to make sure the implants are placed as according to our surgical plan. Okay, so we will be having a short break and we'll be coming back with our Q&A session, the briefing, and a short talk from if maybe possible, from Dr. Lee. Thank you very much. We'll be right back.